Thank you for joining today's webinar. We will be getting started in just a few minutes. All right, hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The nurse planner, content expert, faculty, and others in control of the content today have no relevant financial relationships with ineligible companies. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, if we have time, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenters. Be sure to hit send so that the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. We would like to thank our speaker for sharing their expertise with us today. Of note, thoughts and views expressed are that of the presenter and do not necessarily reflect that of Sigma. Our speaker today is Dr. John Gilmore. Dr. John Gilmore is Assistant Professor and Head of Subject for Adult General Nursing at University College Dublin. Dr. Gilmore's work addresses intersections of social justice and health, and he has a specific focus on sexual and gender minority health. Dr. Gilmore is a Fulbright HRB Health Impact Scholar and has held visiting positions at University California, San Francisco, Columbia University, New York, and Huddersfield University in the UK. Dr. Gilmore, I will turn it over to you.
Thank you so much, Megan, and lovely to be here and lovely to see all of the people sharing where they're coming in from. So many of you from the United States, but also some other places. So really great to see that, and thank you for the introduction. So really what I want to do today is hopefully be able to identify broadly some issues around sexual and gender minority health. I'll use interchangeable terms around sexual and gender minorities, lesbian, gay, bisexual, trans, queer, intersex, LGBTQ. So I'll probably use lots of different terms. But what I want to do is get us to think a little bit around the specific health needs that these groups may have and share a little bit around insights from my context, which is Ireland, as we move towards trying to build LGBTQ health equity. Um, I'm glad Sigma has disavowed themselves of my opinions because I may share some pretty strong opinions, but I'm perfectly happy to disagree with people, and hopefully people are happy to disagree positively with me. So this is a very used slide for me. I use this quite a lot just to kind of state that this is a learning webinar. So we know we're all here to learn. I'm probably going to be doing most of the talking, but I would like us to be open to it also being a place for unlearning. We all bring our own values, biases, and perspectives into a learning space, me included. So hopefully, with some discussion in the questions and answers perspective, I may do some of my own unlearning. I'm conscious that I'm coming from a very particular cultural context, and I'll share some positionality as we go forward. Um, and while I'm more than happy to engage with different perspectives on my experiences. My experiences are my own, and yours are your own. So it's just about kind of recognizing we may be coming from different cultural perspectives. I might say something deeply offensive. I hope not to, but I'm conscious that, we speak in different ways, we use different language sometimes. So if I say something deeply offensive, if somebody else says something in the chat or in the questions and answers, I'm presuming that we're all here with good intent. We're all here to promote health equity and to learn. If I do have any enemies in the audience, I presume they're not going to try and attack me here. But feel free to challenge my thoughts and the research that I'm sharing. And just to be conscious that sometimes some of these issues for some people might be a little bit challenging and may actually discomfort people a little bit. But that's okay. It's okay to be uncomfortable. But it shouldn't threaten safety. If you feel it's a bit too much, then please do log off. I'm getting used to the control panels. So there I am. So just a little bit about me. I'm a nurse, I'm a very proud nurse, very proud member of Sigma as well. So I've had a number of positions across Ireland and the UK in clinically in education and also spent some time in the US as a researcher. Most of my clinical work has been in critical care, but I've also worked in areas of sexual health, of emergency care, of rehab. Um, and more recently, I've done pro bono work in the field of inclusion health or primary care for marginalized groups, particularly IV drug users and those who are experiencing homelessness. But I've always been an activist, and I've always had a drive around social justice. And that, I've done a lot of different kind of activism can be a dirty word with some people now, but really action to better my own life and the lives of others, particularly from marginalized and minoritized groups. I have a master's in human rights, and I think that's what pulled me back into, thinking about activism within healthcare and thinking about a really important constituent part of human rights is health and well-being. And actually, unless you have the fullness of health and well-being and potential of health and well-being, it can be very hard to realize your rights. And if you don't have your rights realized, it can be very hard to be well. Um, I'm a bit of a killjoy, so I don't mind kind of upsetting things. But I do try to kind of have positive intent with what I do. I'm also a Fulbright scholar, so I very thankfully got a chance to spend 7 months in the US, mostly in San Francisco, also a little bit of time in New York. So I have many colleagues and friends in the United States, and I'm particularly conscious that talking about this topic to a group of mostly the US hopefully might spark a little bit of action as well and thinking about the power we have as individuals and organizations. A little bit about Ireland, because Ireland is the center of my universe, but not everybody's. So while Ireland is a very old country in many ways and often thought about, particularly in contexts like North America, as quite an old place, and we've a large diasporic community in the US. Um, but also quite a young country as well. So actually, as an independent country, about just over 100 years old. So we were the initial colony of Great Britain, England, the United Kingdom. So Ireland is very much in a post-colonial embodiment and being. And while Ireland is often seen as and it is in many cases a very progressive country now, that progression happened quite rapidly because when occupation when the Republic of Ireland became independent, when the British forces left the Republic of Ireland, we have had developed what was coined this kind of post-agrarian theocracy. So the church, really, the Catholic Church moved in and controlled most of our social structures, health structures, and that infrastructure. We joined the European Union in the 50s as the poorest country in Europe, and now we're one of the richest countries in the world. Um, but with that kind of strong Catholic control, homosexuality was illegal in Ireland up until 1993. I was born in 87, so I was alive during criminalization of my identity, or people may say acts, but really identity. So Ireland has come a long way. We were the first country in the world then in 2015 to pass marriage equality by a public vote, by referendum. So most people, most voters in Ireland said yes, that people of can have same-sex marriage, and we had gender recognition the same year for people to be able to legally transition. So I remember at one stage somebody commented to me about, it was actually somebody when I was in the US, in one of our consulates said, Ireland is changing slowly. And I kind of laughed and said, Ireland is actually changing rapidly. And because of that, the infrastructure kind of sometimes takes a little bit long to catch up. I'm not going to go into this hugely, just the World Health Organization definition of sexuality. And I often refer to this as the most useful, but also the least useful definition I use in my work. And it's most useful because I think it shows the World Health Organization as an organization and as a group of countries saying that sexuality is really important on so many aspects of life, but also because they say it's basically infiltrating all aspects of life. It can be hard for people sometimes to conceptualize. There are lots of frameworks to help conceptualize sexuality, but yeah, I think my point is that it's important. Some of the terms I'll use: lesbian, gay, bisexual, but I might talk about cisgendered, which basically means that your gender identity, so who you view you are and how you present yourself, matches up with your biological sex assigned at birth or observed at birth, as some people would say. Trans people is an umbrella term for people who don't fall within that, who transition from male to female, female to male, or in other ways. Non-binary, somebody who doesn't ascribe to those gender norms of male or female, man or woman. Intersex is somebody whose biological characteristics of sex are not formed under that binary. So either from a chromosomal or hormonal or an anatomical perspective, sex is not same. And queer might be a term that in many contexts is still quite offensive, but it's something that we use more and more as an emancipated term to kind of talk about everybody. And this is one of the many acronyms, LGBTQIAPD, conscious in a North American environment. We'd also be talking about Indigenous Two-Spirit people, but there are many other terms. And I often will ask people to reflect on, whether this is useful. And a lot of frustration from nurses and healthcare professionals when I do kind of practice development work is that, oh, there's too many terms and it's all another letter, and I don't know how to catch up. And I think there's kind of two things I will respond in that way is, firstly, you don't have to understand somebody's identity, sexual orientation, gender identity to respect them and to respect their right to hold it. But also, actually, as terms evolve, and a lot of terms I find hard to kind of grasp at times, but as terms evolve, actually, what we're seeing is people getting language and ways of expressing themselves that help them feel better about themselves, and that has a positive impact on well-being. So if we think about those, it can be challenging, particularly for those of us who do research. Kind of categories are important, and really understanding how people experience the world is important through that. But I think on the whole, viewing it through an emancipatory lens of people finding ways of expressing and experiencing themselves which are positive for them. There's lots of different ways. This is just one of the visualizations of how we might view issues of gender and sexuality. There are many other ways. The genderbread person is kind of a nice visual representation of, our identity is, who we are in our brain, how we view ourselves. Our expression then is how we show to the world. Our biological sex is around kind of characteristics within our biological makeup that may be identified as male or female. We may have sexual attractions, romantic attractions. Um, so all of these things are for some people very interlinked in a very normative, straightforward way, and for others they might be juxtaposed to each other. Just because we identify if we identify as women, we won't always present ourselves like that. So I mean, being conscious about these differences are important. Um, in nursing, we're a health science profession. Science is very important. Biological realities are very important. I come from a perspective that, a lot of what we ascribe to biology is socially constructed, but there are observable realities. However, these things aren't always as straightforward as we think. So if we think about something like biological sex, a lot of our care as nurses, a lot of the interventions, whether they're medical interventions or other healthcare interventions, are ascribed based on this binary of males get this, females get that, male blood type or male blood results are read like this, females are read like this. And I think what's really important is that what are we actually looking for? And really with biological sex, what we're doing is we're ascribing kind of an overarching term, really that is what we're actually looking for is dependent on that. So we have our chromosomal or XXXY, but again, remembering there are variances within that. So it doesn't just fall in the binary. We then have gonadal sex, so testes or ovaries. We have hormones, testosterone, estrogen, anatomical features, big breasts, wide back, beard, or secondary sex characteristics than beard and body hair. And so I think what's important around biological sex is that while for many and for some, there's quite a straightforward link. So if you have XX chromosomes, you have ovaries, you have high levels of estrogen, you grow breasts at puberty, or secondary sex characteristics in your anatomical features will look like a vulva, but that's not always the case for everybody. And there are, I remember at one point, and the Intersex Ireland, which is a group who work here for people who have differences in sexual development, would say that actually up to 1% of the population of some intersex um, condition or intersex experience. And for those people who are trans, what's really important is that there are various ways to transition. This is from the World Professional Association for Transgender Health, WPATH. And for many people, there's the social transition in terms of how people engage with each other, but also the medical, surgical, legal, and psychological transitioning across that. So being conscious as a healthcare practitioner that, transitioning is not something that just happens at a point of an intervention. It's something that is interlinked with many different perspectives. So the message from this, and I know I'm rushing because I'm that kind of a person, so hopefully people can slow me down in the recording. But I suppose what I want to get across for us as healthcare providers is recognizing that our biology does not always link into how we identify. How we identify isn't always expressed, in a normative way or in a way that might be seen as linking up. That doesn't always link into our desire, and that desire doesn't always link into our behaviors. Lots of my research around gay and bi and other men who have sex with men. So men who have sex with men who aren't gay or bi. For some of those men, they desire other men to have sex with. They don't identify as gay, they don't express as gay. They actually don't, for some of them, and some researchers recently don't desire having sex with men, but they have sex with men because it's there, it's more accessible for them depending on the context. And again, you can have various different ways of understanding this, but it's just that we don't kind of make simplistic perspectives around stereotypes and views of identities. Coming out is a really important phenomenon that many different marginalized and minoritized groups experience, but specific to sexual and gender minorities, it's about that realization internally that we are different in some ways to what's normative in front of us, and then the disclosure of that to others. I think what's important to recognize when we move into thinking about health inequities is that, you know, a lot of what binds lesbian, gay, bisexual, trans, queer, intersex people together is the experience of oppression and identities that are formed under oppression and in opposition sometimes. And what we see in Ireland and right across the world is this kind of juggling act between um, sexuality being criminalized and sexuality being pathologized. So we're either put in prison because we're deviant, or people feel sorry for us because we're sick. Um, and I think as a reflection point, we often think this is a one-way progression, that things are getting better for everybody all the time. Things have gotten a lot better in Ireland for sexual and gender minorities. There are still issues, conversion practices where people can be forced or coerced into what they will call therapies to change one's sexual identity and gender identity are still legal. Um, Also, corrective surgeries, say corrective in inverted commas, because non-medically warranted surgeries on intersex infants, so what might be configured as genital mutilation, is also permitted legally in Ireland. We're told it doesn't happen. We send them to the UK very often, which is what we did with our pregnant women who needed a termination at one point. But I think what we've learned, I think as well, what we've learned, particularly from looking across the Atlantic to the United States, is that this isn't a one-way street, that hard-fought rights can be easily lost, and we need to be vigilant around them. And healthcare providers have a particular responsibility around being conscious around maintaining rights, I think. And again, remembering that oppression isn't just the kind of homophobia or transphobia people experience, the violence, the words, the direct action. It comes from the ideology that, being heterosexual or being cisgender is normal. That's your heteronormativity. This builds into heterosexism, where we build structures, policies, laws which favor one over the other. And that in itself leads to this homophobia, transphobia. And then you get this concept of internalized homophobia, or a kind of drive towards the normativity. Minority stress is probably the best way, well, the best way. I'm not going to say the best way. It is a way of understanding why lesbian, gay, bisexual, trans, queer, intersex people face specific disparities in health outcomes. It's one way. There are many ways. And essentially, it was developed by Aileen Mayer to look at how, that level of discrimination at a societal level and then at a community level can lead to internalized homophobia and negativity, and negatively impact on health and well-being. And we have a plethora of evidence to support minority stress as a direct negative impact on health and well-being, not just from a psychological perspective or a mental perspective, but also from physical health perspective. And I'm not going to go hugely into it, just to highlight it as a model, but there are different types of stressors. There are distal stressors. So there are, very specific experiences of homonegativity, homophobia, transphobia. And then there's proximal stressors like the anticipation. And what we hear a lot from lesbian, gay, bisexual, trans, queer, intersex people is that they expect homophobia and transphobia within the health system. So that in itself negatively impacts. There are loads and loads and loads. Not loads, I lie. There aren't loads. There are a number of kind of reviews of lesbian, gay, bisexual, trans, queer, and intersex research reviews, so scoping reviews and systematic reviews around health outcomes. These are just some of them that kind of highlight some of the health inequities and outcomes that are there. Um, by and large, what we see is that lesbian, gay, bisexual, trans, queer, and intersex people, they face health inequities where we look for them, which is always telling, that usually when we go and look at whether there's a specific disparity, we'll find it. We don't have huge amounts of evidence, because it's an under-researched area, but when we look for it, we find it. There's quite strong research in the fields of mental health, emotional health, substance use, sexual health disparities, and HIV disparities within certain groups. And these are just some of them that I've linked in the reference list as well. But what I want to talk about is scoping review, which will be published hopefully this year at some point, that colleagues in the US suggested that we could work on together, which was really great. So we have a team of, I think, 9 or 10 researchers from the United States, from Columbia University, from San Jose State University, and from a number of universities in Ireland, who came together to look at what is the LGBT health research uh, in Ireland from an Irish context. What's health research like here? So we had almost 60 papers, I think 60 papers, 59 distinct studies, which looked at, what was published out there in the peer-reviewed literature. Now, there's more literature out there in terms of what maybe community organizations have done, but in terms of, you know, high quality evidence or peer-reviewed evidence that is the basis of policy and practice. This is what we found. We were surprised a little bit that um, we thought, well, I presumed maybe because the type of work I do mostly with sexual health that there'd be mostly sexual health research, but actually we found there was we mostly categorized when we categorized them as mental health, then sexual health, then we had some general, then we had substance use and cancer and some around gender experiences. Unsurprisingly, most of the studies were around gay and bi men and other men who have sex with men, very little on women, and nothing on intersex. This isn't surprising. I often say I go to LGBT health conferences, a bit. Um, and oftentimes what we see is it's a big G for the gay men and bi men, and then there's a big T for trans people now, and that's pretty new, but very little input around sexual minority women or other marginalized groups. Most of the studies that we looked at were surveys or quantitative research, like retrospective chart reviews, etc., with the next level being qualitative studies and then some mixed methods as well. So mental health was the largest area. So again, we were just seeing higher, um, not always rates because it wasn't always kind of on clinical data, but higher signs and prevalence of mental health issues within groups. And specific studies were specifically discussing issues of minority stress, discrimination, but also the lack of specific mental health supports for lesbian, gay, bisexual, trans, queer, and intersex. We see ongoing barriers, particularly around the areas of cultural competence, but also negative behaviors within health settings and particular subgroups. There were some particular subgroups which looked at sexual minority women and bisexual people within this group. Um, and yeah, and particularly with students as well. So then we saw, higher prevalence, but also kind of risk factors around HIV and sexually transmitted infections. Um, so again, HIV is still an issue. Ireland is, well, we're starting to be less of an outlier, but for many years we were an outlier in Europe, where when most of the European Union's HIV rates were coming down, ours were rising. There was an issue around reporting inward migration. So people who were already living with HIV who came to Ireland, we were reporting them as new infections rather than existing infections. But there was a trend upwards, and it was something we were needed to be quite conscious of. Um, Issues around sexual health education were highlighted in some of the studies. But one of the positive things we might look at and we might think about is actually with the gay and bi men, there was kind of a high vaccine accessibility. And one of the studies not in this scoping review because it falls outside of the years was some research we did on the experience of Mpox or the community needs of Mpox or monkeypox in Ireland among gay and bi men. And again, that was something that definitely came up. Very health ready group. Um, Significant issues around gender affirming care in Ireland. Uh, High kind of crossover then as well within mental health comorbidities within this particular population. Ireland is ranked worst in the European Union for transgender health. We have a single service to provide gender affirming care in terms of cross-sex hormones and sex. We don't do gender affirming surgery in Ireland for trans people. There is a surgical pathway abroad that we support them, but very high because it's a centralized system, very high waiting lists. So, it's a big issue within communities of trans people. Um, there was some research on substance use, particularly on gay and bi men. So this phenomenon of chemsex, where sexualized drug use of certain drugs was particularly highlighted. And then there was some other studies specific to cancer, but kind of around some interventions around cancer awareness, and then looking at older LGBT people. One of the things that came up in some of the studies and was commented on many of the others was the the role of community support and kind of the protective role, and it's a slide I'll finish on later, but the need to talk a little bit more about some of the positive aspects of LGBT health. These are just two graphs from studies that were done on broadly the mental health and well-being of lesbian, gay, bisexual, trans and intersex people and the initial study, and they had a bit more broader view on the later study. So these were both conducted by my colleagues in Trinity College Dublin, Agnes Higgins. And one of the things that we might reflect on is that we have, significantly higher rates or higher signs in terms of scores. So these are not clinical. These are not clinical diagnoses, but they're indicators based on a tool, the depression, anxiety, stress, suicidality scores. But they are much higher amongst lesbian, gay, bisexual, trans communities, even higher with trans people and young trans people. Um, I think one of the things to be a reflection point for us is these studies were 10 years apart, and actually, despite rapid kind of progress, visibility for lesbian, gay, bisexual, trans, queer, intersex, there hasn't been an improvement in mental health. So, we need to be really thinking about this catch up. And I think that thing around changing quite quickly is an issue. In Ireland, we still have significant, so waiting list. Our National Gender Service, which is a service, a publicly funded service, which provides gender affirming care, talk about a significant waiting list. So they're currently seeing people, I think, who were referred initially 4 years ago, 5 years ago, but because the demand has increased for their services, it's likely that there's a lot longer waiting list. So a lot of people self-source their medication. Um, this is a study I've just it should be published very soon, but this is kind of asynchronous online focus groups. So where I brought people, members from communities together to discuss online on an online forum their experiences, preferences, and needs around healthcare. So we had about 50 people recruited initially, and 43 different people kind of got involved in three different focus groups. So there was one which focused on gay and bi men and other men of sex with men, one who focused on lesbians, bi, and women of sex with women, and a third that focused on trans communities. Now, people who were trans may also be in one of the other groups, but so people could choose which group they went into, and they were able to interact in this virtual platform, I think, for 2 weeks. And it was supported by various community organizations. So, quite a good sample for a focus group, but it was online, which made it a bit different. So what we were seeing was kind of discussions across the groups around, the importance of culturally aware healthcare practitioners, but also the paucity in them. A lot of people had negative experiences because of just being misgendered, having intrusive um, questions about their sexuality or their sex lives or their bodies, and that was kind of across the board. Access was a big issue, particularly in the trans group, but across the board, kind of the access to kind of appropriate healthcare service. This debate kind of was coming up within the focus groups about, whether or not, we should have all healthcare practitioners. You should be providing, healthcare for lesbian, gay, bisexual, trans, queer, intersex, or should we have specialist services? In Ireland, we have that National Gender Service, which is the only publicly funded service that does that kind of work, which in itself creates a problem of access. And we have a gay men's health service that does sexual health for gay and bi men and trans community. But it's this kind of debate around whether or not we should have specialist services where people know they're going to get really positive care, and they're going to not be misgendered and get culturally appropriate care, versus that being in itself limiting, because every healthcare should be. And then again, similar to kind of when we saw that within the scoping review, that was the biggest issue within this study as well. Mental health support was specifically discussed as something to be considered. Um, in terms of moving forward, I think one of the reflections I often have around this area of healthcare is actually our data is quite poor. It's that, we only get the tip of the iceberg. what we see more and more is when people look for, if people decide to do a study on LGBT health or lesbian health or gay male health, and they look for health inequity, they'll probably find one. And again, we can come back to the minority stress model or many other models in terms of understanding how stigma in healthcare, how structural issues impact. Um, what we see is that we tend to focus on very specific areas like HIV and STIs, like mental health, like substance use issues. So, and they often come from quite stereotypical perspectives of, oh, those LGBT people experience discrimination, therefore they must have poor mental health outcomes. So, a big issue for us in Ireland and across most health systems is there's a really poor integration of sexual orientation and gender identity data within the health system and within the health research system. Um, I'm conscious as well, again, speaking to an audience mostly in North America, this is getting harder in the United States as well, in terms of, what large funders are funding. If we don't ask the questions, we're not going to get to see the visibility. Um, so we need to build in legislative frameworks to ensure sexual orientation, gender identity, or data, sexual orientation, gender identity data is collected. And we need to make sure it's collected in the right way, in a culturally appropriate and sensitive way, but also that the data then is used to develop specific interventions. And that's the big, I suppose, question for clinicians. Researchers, we want to know everything about everyone. But it is a question, should all clinicians be asking all of their patients around sexual orientation and gender identity? And there's a lot of differences of opinion here. I often ask this in a classroom to nursing students and midwifery students, and you get most people will say, yes, we should ask all patients, but they know that because I'm teaching them. And then most will say like it depends. But I think the other thing is some people say no, and some people say no from a protective factor that, actually, you know, they feel this is private information or it's information that may kind of put people at risk. And that's something we need to really reflect on in healthcare, that, there are people who have negative perspectives around sexual and gender minorities. So by providing the data, it may put people at risk. There's lots of challenges around sexual orientation, gender identity data, analytics, and kind of this crossover between behaviors, identities, experiences, expressions. Um, so there are very practical perspectives around the workflows around electronic health records. Ireland, we don't have a national electronic health record, or we have very poor integration of electronic health records. We are building a national electronic health record over the next 5 years. I love the shocked faces. Yeah, I mean, we're the tech capital of Europe, but we still get a paper chart when you come to hospital very often. Um, but also challenges around the discomfort of the doctor, the nurse in asking the question, or the researcher, and then the discomfort from the patient perspective or the research participant. So, it's not simple, and I think it is something I'm trying to work through in a bigger project around how are we using the data and how do we build it in to be effective. So similarly with that biological sex conundrum, if I really need to know somebody's hormone levels, it's not their biological sex I need to know, it's their hormone levels. If I need to know somebody's anatomical makeup, it's not how they identify, it's what does their anatomy look like, and how is it experienced. It's really important we start to think about this in our healthcare professional training and education. So this is a framework I've developed, which has just been published in Nurse Education and Practice. I published it earlier in another paper, but we built out with some other colleagues the concepts a bit more. So usualizing and specifying. And essentially what we're saying is that in order to meet the needs of sexual and gender minorities, we first of all have to usualize them into our health system, into our knowledge. So that means that, we just build into case reports when we're teaching nurses that, Judy and Jane come in and they're married women and they come in and Judy is Jane's carer and, there just happen to be lesbians. We're not talking about lesbians today, but lesbians came in. So that's really important to kind of, recognize that lesbian, gay, bisexual, trans, queer, intersex, and other sexual minorities are in every aspect of health, delivery and recipients. Um, but also kind of we need to move into a space of also specifying because there are specific needs that sexual and gender minorities will have that we know through research in health inequities. So it is important that we do recognize that gay and bi men are more likely to, or have many have higher risk characteristics when it comes to HIV. So that's important that we do talk about HIV in gay and bi men, that we don't ignore it because we're just talking about gay and bi men in a general sense. So that's the model. And this is really kind of from two other studies of what we're trying to avoid. We're trying to avoid the fetishizations. This is a study I did in Gay by Men, qualitative study on experiences of healthcare. And they talked about really, whenever they came out within a healthcare context, um, they first of all were always presumed heterosexual. And this is a while ago. This is mostly with general practitioners or family doctors. Um, they were mostly presumed heterosexual, but when the penny dropped that the man in front of you was gay, kind of a HIV test was first and center, which you know, the person wasn't there for a HIV test. They probably knew more about HIV than the doctor treating them. But it was kind of this sexualization and fetishization that the only reason you're in here and you're coming out is because you are, um, you must be a risk of HIV. And then trans obsessionism builds on that concept of trans broken foot syndrome, where the only thing the clinician looks at is the foot, but also sometimes trans people experience a lot of negativity from healthcare providers where they're health issues are blamed on their transness. So whether that be kind of their functionality or other parts of their health experience. So that's what we want to avoid. Some observations for I had a great time when I was in the US. So I have pictures here from Callan Lord and from Bellevue in New York and from the LA LGBT Center and Strut, the Magnet Center in San Francisco. And like what I saw here. So I did research with a number of clinicians and I visited a number of settings and I visited private, federally qualified community services, lots of different ways in which healthcare was being delivered. Um, and some really great kind of insights around the people who worked there. Like they saw themselves not only as clinicians, but also as leaders and also as activists and also part of the community, whether they were queer themselves or not. And that was really nice to see and something that, I would love to see emulated in Ireland. Many, when we think about, how healthcare is developed, like many of these services came from crisis. They came from, the HIV and AIDS crisis in the 1980s and 90s. But that brought together a community to respond to a crisis and has built out from then. And there was usually really good community governance as well. So queer people were often the clinicians, but also if they weren't, the community had a real voice. So I think there's a lot of learning um, around that. These are kind of some of I worked for many years in the NHS and the HSC, rainbow badges, rainbow lanyards. I think it is really positive, I think, to visibly show your allyship for sexual and gender minorities as a clinician. But I do think, allyship is, a verb. It's, we need to act, so putting on a badge shows something, but have we done the work? Do we understand the experiences? And I think we just need to be cautious around, investing too heavily in these visible perspectives. On that study of gay and bi men, one talked about the armor that's built up around expectant or that kind of distal stressor around perceived homophobia or expected homophobia. And this guy talked about, I remember him talking about you see a rainbow in the waiting room and you think, wow, you let your guard down. And then you experience homophobia in the clinical room, and it's so much worse than if you had your guard up. So I think we just need to be conscious, should we be putting flags outside our hospitals if we cannot guarantee that everybody in that hospital is going to treat that person in an affirming way? It's a question for us to think about. Another, thing we really need to think about is that queer people don't just live lives which are impacted by homophobia and transphobia. So people may be aware of, I hope are aware of Kimberly Crenshaw's work, which was based on earlier work of other Black feminists, and basically, recognizing that for many people, many sexual and gender minorities, They may also be disabled and facing ableism. They may also be black and brown and facing racism. They may also be poor and facing, socioeconomic discrimination. So, and and recognizing that, creating a really fluffy, woolly, dancey, don't know why those words came together. Flag raising ceremony of the LGBT progress flag outside is no good if you're going to be racist because there are black queer people. It's no good if you're going to be ableist because there are disabled queer people. So it's about recognizing the multiplicity of oppression and trying to build that in when we're doing queer work. So when we're queering something, like when we're, the utilizing and specifying, when I'm using that to queer the curriculum, I should also be thinking about how black and brown identities are embedded there. So we're, dealing with racism, how disabled bodies are being built there. So it's about keeping that lens together. We need to recognize and think globally. This is an early ILGA rights map, so I think some colors may be changing for some countries. But we do need to recognize that in many parts of the world, it's not even okay to talk about this. Um, and it's something we need to be conscious of. We will have people maybe coming to our services who've experienced different perspectives. Again, presuming good intent, but also recognizing different experiences and how safety impacts that. There are still a number of countries in the world where you can be killed for being homosexual or trans. And there are various different iterations of how those legislative forms are there. And this is how I like to end these. I think one of the things, this is me in the front of San Francisco Pride, representing Ireland. This is the in front of the Irish delegation. And I think one of the things I'm starting to think a lot more about is how we integrate discussions and considerations of queer joy and queer kinship and community. When I think about those services I viewed and I visited and I got to meet the people, in some cases, people who founded these services, um, you know, there's something protective and um there's something protective and there's something, that we can really learn from queer communities and how we've cared for each other. And if we look at how queer communities came together to care for those who were impacted by HIV and AIDS, if we look at how we're continuing to do that in various different pockets, we can learn a lot as a wider society around that. So it's something I want to start doing a bit more than looking at health inequities, but it is important to highlight the problems and the issues too. So thank you very much. I'm slowly exiting. I'm basically gone from the app formerly known as Twitter. But I'm on Blue Sky, which is the new cool place to be apparently. Or LinkedIn. You can find me easily. I'll also hopefully be at the Sigma Congress for anyone who's there this summer in Seattle. We'll see. Uh, that's the plan anyway. And then I have references and publication list, but I don't know, they're towards the end, so they're available. I don't know what I've just done with this. So yeah, so various references and some of my own publications are linked there, and they'll all be linked to the presentation. So I am happy to have finished because I rushed. So I am really hopefully we'll be able to take some questions. I'd really love to hear from you.
Yes. All right. Thank you, Dr. Gilmore. As he's mentioned, if you have any questions, you'll see you can use the Q&A feature to send those to us, and then we can start the discussion. Let me pull up the questions we have so far. The first question, if you could clarify, what is pansexual and demisexual?
I wonder sometimes myself. So pansexuality, I mean, I often use this as an example. So for many people, who I know who identify as bisexual, they are not restricted in terms of gender. So they like people of traditionally what we might have said, both sexes, if you can use that term. But for most of those people, they're all saying, well, I just don't discriminate based on gender. But pansexuality is more explicitly that. It's that, you're more open to creating romantic and sexual relationships with people of all and any genders. So they might be non-binary, genderqueer, trans, cis, whatever. And then demisexuals tend to have be more driven towards intellectual and uh, intellectual is the wrong word, but they're more connected in terms of less aesthetically attracted to people and more based on personality, etc. They are probably awful descriptions, and that's probably something awful offensive to the pansexuals and demisexuals in the audience, if there are any. But that's my understanding. So that's that one.
Okay. Thank you for sharing this wonderful information and content focused in research. As you probably know, the United States is going through some changes in health policies. What can you recommend for providers who want to see LGBTQI plus patients but face resistance either in their healthcare system or from national regulations?
Um, I mean, I have to send a whole lot of solidarity. These are people, these clinicians are people I know and I love, and I have learned a huge amount from, and the researchers as well. I mean, there's something about um resistance, but also self-care. And I think Audre Lorde, really kind of got us to reflect on self-care in itself is political, that we can't, and in nursing, I think we're not always great at this. We often try to care for others. So I think that's first of all important. We can only do our best and create the resistance in ways that we can. But it is challenging, and I think sometimes, and I'm not this kind of person. Um, I'm involved in a network, and which has I can't say too much about it, but has a US kind of connection, and I'm on the DEI panel, diversity, equity, inclusion panel of this network group organization, and we made a decision last year, or not last, was it last year? May, no, it wasn't last year because there wasn't a particular event occurred at the start of our happened at this year. So but we made the decision to change the name of our panel from a DEI panel to just a generic panel. And I would normally resist that to the nth, but because of changes in the United States, our concern as a panel was that a diktat would come out from a federal agency to say there's no DEI anymore. So we're able to do what we're doing. We just don't call it DEI, but it's still the whole function of the panel is around DEI. But we've just changed the words, and we shouldn't have to do that. Um, but that's the reality. And I think one of the things I say to, I identify as an activist, that's where I am. But I think people do that in various different ways, and we can only do that as much as we can. And I think having a bit of compassion for ourselves, but also for others is really important in this point.
All right. As far as intersex individuals, how should this be captured within the EMR, or should it even be captured?
Really interesting. I think first of all, intersex for many people is an identity. So I am, or I might say I'm male, when somebody's categorizing my sex, and somebody else might say they're female. Some people will say I'm intersex. Some trans people will say I'm biologically male, but I'm a woman. I'm biologically female, but I'm non-binary. So gender identity and biological sex are two different things. I think we're just kind of figuring out how to do that. There are health record systems that will categorize somebody as intersex. So instead of MF, they'll put an X there. But I wrote a paper actually, it was published last year looking at because I'm, coming back to my ICU roots, ICU is the intensive care unit is a very physiologically driven, environment. We're person-centered, but we focus a lot on physiology and normal and pathological physiology. So again, we were kind of talking through this case of, how do you look at the biochemistry of a transgender woman? Because this woman is a woman, so you treat her as a woman. That's great. But, when we look at biological determinants, this woman was born male. But actually, for most of the biochemistry we're looking at, it's really the hormonal levels. And this trans woman has been on cross-sex hormones, and this particular case we used was post-surgical. So her hormonal profile was that of a cisgender woman. So therefore, you'd look at her that way. But for another physiological driver, such as ideal body weight, you know, her body composition maybe more suited to that we'd categorize as a male because we use ideal body weight for ventilation settings. So again, depending on, what type of puberty this person went through, how their body's been composed and developed. So again, I think we finished the paper like every good nursing paper, we need to be more person-centered. And I say that with a bit of jest, but actually that is the essence of it. It's thinking critically, deconstructing these concepts and saying, okay, what will make a difference for this person? But yeah, capturing you can capture by intersex with an X. I mean, if it's in the system. The challenge as well with that is our systems are, with AI and with algorithmic thinking, it speeds up our work, but also sometimes you do need to think a bit more critically. So having automated perspectives of if this person meets these three characteristics, you give this therapy can be a little bit dangerous in all areas.
Thank you for addressing that.
Hmm.
This person says, as a sexual assault nurse here in the United States, I am curious about the rates of sexual violence against LGBTQ plus in Ireland and the reporting rates.
So there is upcoming research which hasn't been published yet. It's not in our review. Our review did 2014 to 2024, but there is an EU project looking at this, based at Dublin City University, and there are some other studies going on. Actually, we're with colleagues at Dublin City University, another group. We are going to do the first prevalence study of all types of abuse, intimate partner violence, and other forms of abuse amongst sexual and gender minorities in Ireland, with some colleagues there who are abuse specialists, using various different scales. So we don't have hard data on that, but there is, if you look up Dublin City University, IPV, LGBT. I can't remember the name of the researcher right now, so I'm sorry to that person, but I do know what's happening. So I'm not sure, but there's a lot of a really good friend of mine, and somebody I worked with when I was in San Francisco, Dr. Nick Matheny, who's a professor, assistant professor of nursing at Emory, does specific work on sexual IPV, sexual assault, among sexual and gender minorities. So he's a good person to look up.
Okay, we have so many questions.
Good.
I'm trying to narrow it down. Okay, so this person says, I know lesbian health is under-researched. Where might be a good place to start?
Where might be a good place to start? I think just making lesbians visible. My mentor, one of my mentors, I don't know if she'd agree with me calling her a mentor, but who did the scope review with us is Tonda Hughes, who's one of an incredibly impressive researcher based at Columbia University, who has really driven forward kind of sexual and gender minority health in general as a leader and as a nurse, but has specifically worked on sexual and gender minority women and done a huge amount of work. But I think the more people getting involved and raising those issues are really important. But it can often be a visibility. And I think an openness, for the rest of us who work in the LGBT field. Obviously, we need more people doing LGBTQ plus research, full stop, but creating some space and always making sure that there's a space within our work for sexual and gender minority women and trans people and intersex folks, I think is really important.
Have you had any experiences engaging with policymakers and legislators about your research and advocacy? If so, how did you frame or go about those conversations?
Thanks. That's a great question. Yeah, it's a lot of the work I do. My master's in human rights and social policy, so I am very kind of policy focused and driven. Ireland is easier, I have to say, because it's smaller. So, that the person I spoke about earlier, Professor Tanja Hughes came to visit, and I was able to bring her into government buildings and meet with senior cabinet ministers. And that's not because I'm a really important person. It's just politicians are more accessible in Ireland. I think sometimes finding shared space and shared language, I think it can be hard in certain contexts. Like I mean, you know, I didn't ever think that places like, well, for lots of reasons I should have thought, but places like the UK and the USA, human rights should have been like a pretty standard baseline, generic, non-offensive thing to talk about in that generic sense. But even that now is becoming harmful. So I think it's finding some kind of a shared language that, one can move forward with. Sometimes it can be economics, and more sick people, more queer sick people cost more money. So sometimes it can be some of those issues.
Okay. Sorry, I'm trying to narrow it down because I know we
Well,
have not a lot of time left. Um, so in the United States, the conversation around surgical interventions has shifted to children and the ethics of allowing such finite interventions before they are old enough to be considered as an adult. Um, and I know you mentioned with Ireland, you
yeah.
outsource that surgical interventions, but
For
um,
intersex,
okay,
not for trans kids.
okay.
I'm not a specialist clinician in gender affirming surgery. I do know some, and I'm close to some, and work with lots of people who work in the space. But what I will say is that for people who are specialists in this field, they would say that, like, there these children, it's okay, there will be these children that exist somewhere, but there's such a tiny proportion. um, like any surgical intervention with a child, the first port of call is parents and ethically driven clinicians. So you rely on both. You rely on parents to have the best interests of their child. Some parents don't, but then you have the ethical clinician who's going to spot that. So, I think we've moved to the extremes very often, whereas actually what we need to be talking about is how kids can, if they're having difficulty with their gender or kind of how they view themselves or how others view them, like creating spaces where they can talk about that, creating spaces where they can learn about that, explore themselves. I think that's the first step. Um, Rather than thinking, how are we going to handle all this surgery on kids? It's such a small, so we don't have any surgical pathway for children in Ireland. We currently don't have any medical transitioning pathway for children in Ireland. Our child and adolescent mental health services will see trans children, but there's very little. Parents and children will talk about a big lack of support for them.
All right. For those that may still have remaining questions, let me go back real quick to Dr. Gilmore's contact information here because we weren't able to get to all the questions, but thank everyone for your engagement during this session. Dr. Gilmore, did you have any closing words that you wanted to impart?
No, I just love to be here. Thank you to Linda and the team at Sigma for inviting me. It was great to be able to talk to you all. For anyone at the Research Congress, I'm going to be there hopefully in Seattle, so come and find me if you're there. Or yeah, get in touch. And yeah, things will get better. I'm hopeful. Let's be hopeful. And yeah, really, hopefully, you enjoyed it. And if there's any feedback you have directly for me, let me know. And if not, through the Sigma folks. So thank you so much.
Thank you, Dr. Gilmer, for sharing all this information. There's been such great response, and I think everyone has learned a lot today. So thank you for taking the time to share with this audience, and we look forward to hearing more from you at upcoming conferences.
For
We hope you've
sure.
enjoyed this webinar. To complete the evaluation and obtain NCPD certificate, please click the link that we've just posted in the chat. It will also be emailed within a week of the webinar, a link to the recording, the slides, and the evaluation if you're unable to complete the evaluation right now. But again, we thank you and we hope you have a wonderful day.